So, our final keynote. So first of all, to say that I'm very grateful to Joe, because we had asked Joe to do the keynote and asked him to do the keynote in the morning. And then when Pippa Haling said that she could only do it in the morning, Joe very kindly said that he would listen to everybody speaking and give us our afternoon keynote, which I think from a conversation we just had over tea has been useful for Joe in terms of understanding who's in the room. So but I have no doubt that Joe is going to give us a fantastic keynote. So Joe has an awful lot of titles: a Professor of Tropical Medicine and International Health at the London School of Hygiene and Tropical Medicine, and Research Associate at the Botswana Harvard AIDS Institute Partnership, based between Gaborone in Botswana and London in the UK. Joe's main research interests are advanced HIV disease and opportunistic infections, and he's worked with the WHO on that. He was chief investigator for the Ambition study, which was a multi-center phase 3 trial. And he also works as a consultant physician in infectious diseases and HIV medicine. And before I want to hand over to Joe, I just wanted to say that everyone's spoken about it today, that ultimately people are at the heart of all that we do. And I think for me, over the many years now that I've been involved with Cambridge Global Health Partnerships and health partnerships, is the friendships that I've formed with many people who are here in the audience, and that includes Joe. So we were just remembering that we met through a Cambridge connection that I had, that Joe then had with him at the London School. I had moved with my family to Botswana. Joe was considering moving with his family to Botswana. So we met in a hotel in Botswana to kind of share experiences of moving our young families, where we would send them to school, etc., etc. And then here we are, 11, 12 years later, just reflecting on how fortunate we have been, also that our families have had the opportunities that they have had through the work that we have done, and all the amazing people that I've met, but also I know that my children have met through this work. So it's fantastic that Joe's been able to come today, and that we've been able to see each other again after many years. So, Joe, thank you.
Great. Well, thank you very much, Evelyn, for inviting me. It's lovely to be here. It's been a wonderful day of talks, hearing the breadth of work that's going on, and hopefully what I'm going to talk about will touch on several of the themes that have already been raised. And Evelyn, thank you for inviting me. I inherited all of Evelyn's children's school clothes, so my children went to school in Botswana for 5 years with Brearley name tags in the back of their T-shirts. So my talk today is about translating research evidence into global health policy. And I'll be talking about what I'm most interested in, which is HIV-associated opportunistic infections, but hopefully this is translatable across the whole spectrum of global health work. So in terms of an outline for the talk, this is what I'll be doing. First of all, I'll be setting the scene. So for those of you who are new to global health, what this involves is showing lots of maps with some countries colored in red and explaining why my disease is more important than your disease. So once I've done that, we'll talk a bit about HIV-associated cryptococcal meningitis specifically, and why there was a need for new treatments. I'll talk about the trial that we've completed about 2 years ago now, called the Ambition trial, why we did the trial, what we found, but then most importantly, the pathway of that trial into global impact. How did we translate those research findings into policy? How did we go beyond getting it into policy into actual patients and to the bedside? And what do we do after a big trial like that? And then I'll finish by telling you all why it's very important to attend the drinks reception. So I realize that I'm the only thing standing between you and the drinks reception, that it's getting dark outside, it's cozy in here, but hopefully you'll all stay awake for the next half hour or so while I go through this. So, setting the scene, if you're the same age as me and you lived in the UK, you will remember this coming through your letterbox. Don't die of ignorance. I was quite a young child. This was 1986, so I was 10 years old. That ages me a bit. And this made a major impression on me, as I'm sure it did many other people at that time. And the HIV epidemic or pandemic really was the defining global health event of our generation. There were terrible pictures like the one at the top. This is from the Middlesex Hospital HIV ward of young men dying from a completely incurable disease at the time. And it became apparent that what people had feared would unfold in the UK when these leaflets were put through the door had already unfolded across much of Central Africa. And that picture from the bottom is from a book by somebody called Gideon Mendel called The Broken Landscape. It's well worth looking at. It's profoundly distressing, but it's a documentary really of the early days of the HIV epidemic in Central Africa before there was any treatment. And the impact of the HIV epidemic in Africa can't really be overstated. So this is a graph. It's quite clear what it shows. That's life expectancy. And you can see what happens in the mid to late 1980s across the African continent to life expectancy directly as a result of a single infectious disease. And the line in red there is Botswana. That's where I've spent a very large part of my professional career. And you can see that by 2003, the life expectancy, average life expectancy in Botswana had fallen to just 37 years old as a result of the HIV epidemic. People were dying, unbelievable numbers of people dying. Saturdays were taken up with funeral after funeral after funeral. And the president of Botswana at that time, President Mahai, went to the UN General Assembly and he gave this speech. And he was quite clear, and you can see from the graph that he was right. We're threatened with extinction. People are dying in chillingly high numbers. One more day of delayed action is a day too late for our people. And he made a call for assistance from the global health community to address this catastrophe across Africa. And the global health community stood up to the challenge. And by these are slightly out of date data now, but you can see that by 2018, in Botswana, HIV had gone from a catastrophic disease that was killing large swathes of their young population at the prime of their working lives to a chronic controllable condition for many, many people. So antiretroviral therapy had been developed and had been rolled out across the African continent. Botswana was one of the first adopters of a free ART program in Africa. And by 2018, 91% of people in Botswana knew their HIV status, had been tested. 92% of them were on treatment. And of those people on treatment, the vast majority were virologically suppressed. So a huge public health success. But why am I here and why am I still talking about HIV and opportunistic infection when to many people, the narrative has changed to this. Now, HIV is a chronic disease. It's something we can live with. We don't need to worry about those horrible stigmatizing pictures that I showed you at the beginning of skeletal people dying of AIDS. But even though modeling data suggested that if we rolled out antiretroviral treatment widely, we'd see a very rapid decline in AIDS deaths. It's shown in the bottom graph there. It's a bit hard to see, but the green line is suggesting, well, if we roll out widespread antiretroviral therapy, we should see quite rapidly AIDS deaths declining to almost nothing. So the expectation was that this is what would happen. And a lot of the focus in the global HIV response was put on viral load monitoring, on treating HIV as a chronic condition, about destigmatizing HIV and AIDS. But these are the most recent data from Botswana. And you can see there on your right, that's the prevalence or the number of people in Botswana living with HIV. It's about 20% of the entire adult population of Botswana in 2024 are living with HIV. This problem has not gone away. In the middle is the graph of coverage. The axis at the bottom, 2010 to 2022, you can see the coverage of antiretroviral therapy. The proportion of people with HIV on treatment has gone from 50% up to nearly 100%, so about the 90% mark. But look at what's happened. If you look at the 2010 to 2024 bit of the deaths graph to deaths, you see that deaths have come down, but they've plateaued. And they've really not moved much over the course of the last decade. And so we're still seeing about 630,000 people, these are UNAIDS estimates, dying of AIDS every single year in 2024. This problem has not disappeared. And why is that? Well, One thing is that people are still presenting to care or being tested once they're already quite sick and have advanced HIV disease. These were data presented at the Big AIDS conference in Denver earlier this year. It's been published yesterday in Clinical Infectious Diseases. And you can see that across the world, about 30% of people at the time of diagnosis with HIV already have a CD4 count of less than 200, what we formerly would have called AIDS, what we now call advanced HIV disease. So a lot of people are presenting late. But even more of a problem than that is the fact that the treatment cascade, as we call it, is not a nice linear graph like I showed you in that slide from Botswana of people being diagnosed, starting treatment, becoming virally suppressed. Life is complicated, people are complicated, and the cascade is complicated. People cycle in and out of treatment. They start treatment, but then they stop treatment. Life gets complicated. They can't adhere to their medication. They can't make it to clinic. And this problem has been, I think, massively underestimated and is only becoming apparent now as we get to this very mature stage of the epidemic. So these are data from the Western Cape province in South Africa, which has probably the best ART treatment program in the whole of the African continent. This is a cohort of about 70,000 individuals. And in this cohort of 70,000 people initiating treatment, the cumulative incidence of interrupting your antiretroviral treatment within the first 5 years was 70%. So the majority of people are having an interruption in treatment quite soon after starting ART. And the median duration of these interruptions was 7 months, which is long enough to have a very precipitous drop in your CD4 count and develop opportunistic infections and get unwell from your HIV infection, and also, of course, have a detectable viral load and put your intimate partners at risk of acquiring HIV infection. So AIDS has not gone away. And if you look at what's happening in hospitals across the region, that's reflected in what we see. So these are some of the most recent data I could find. The top one is a paper from Uganda published this year. 19% of all hospital admissions in Karudu Hospital in Kampala are due to HIV-associated illnesses. In Botswana, some data from, again, published 2020, so not that long ago, 42% of all medical admissions are people living with HIV, the majority of them with AIDS-related conditions. So in areas of high HIV prevalence, this makes up a very, very large proportion of what we're seeing in hospitals and what we're having to deal with. What happens to those people when they go into hospital? Well, bad things generally. We know from comprehensive systematic reviews that 20% of them or so will die during the course of their hospital admission, 1 in 5. And we also know that another 1 in 5 will die in the month or two after hospital discharge. So inpatient management of HIV remains an area where we really need to do some work to improve outcomes. And we recently wrote an opinion piece. Nathan Ford is head of guidelines at the World Health Organization. Peter Ehrenkrantz is head of the HIV division, or was until recently, at the Gates Foundation, making the point that with all of the focus on expanding treatment and destigmatizing HIV, we've kind of forgotten that a lot of people are still dying, and they're dying of AIDS, and we really need to start focusing again on this if we're properly going to end the AIDS epidemic and HIV as a public health problem. So when people are dying of AIDS, what are they dying of? Well, consistently, it's 3 main things. It's bacterial infections, it's tuberculosis, and it's cryptococcal meningitis, a disease that many people in this country have never seen, in fact, have not really even heard of. So what I'll talk about for the next bit of the talk is cryptococcal meningitis, what it is and why it's a problem for us and why we need new treatments. So Cryptococcus is a yeast. It's around us all the time. We breathe this in. There's serological evidence from studies in America that by the age of 5, 70% of us have antibodies to this infection. So nearly all of us in the room have breathed in Cryptococcus. It floats around, it rots the dying wood of trees, birds carry it round in their droppings. But if you have a functioning T-cell mediated immune system, it won't cause any problems. It will get into the lungs, it'll either be cleared completely or it causes a latent infection, no problem. But if your T-cell mediated immunity wanes for any reason, then it can reactivate, disseminate, and it causes a devastating meningoencephalitis. And the main reason that people have defects in their T-cell mediated immunity globally is HIV infection. So this is really an opportunistic infection in the context of advanced HIV disease. And it's a major public health problem. Here's my map with the red countries on. So these are global burden of disease estimates that we put together a few years ago. We estimate that there are around 180,000 deaths annually from this, which account for about 20% of all HIV-related deaths globally. And it's by far the commonest cause of adult meningitis across southern and East Africa and parts of Southeast Asia. So in Malawi, it accounts for 70% of all adult meningitis, about 33 to 45% in other series from across East and Southern Africa. Similar data from parts of Thailand with high HIV prevalence. So it's very prevalent and it's very common, and it remains a common clinical challenge for clinicians working across the Southern and East African region. It's extremely difficult to treat. So if we don't treat cryptococcal meningitis, the mortality rate is 100%. It's universally fatal. Across most of Africa, and I'll talk you through this in some detail in a minute, the treatment for many, many years has been oral therapy with a tablet called fluconazole. It was donated through a Pfizer donation program. It was easy to give. The problem is that at standard doses, it just doesn't work. Mortality rates have been reported in clinical trials of about 70% at 10 weeks. So 7 out of 10 patients dying with that treatment. Conventional intravenous therapies with a drug called amphotericin B deoxycholate are more effective, but they require prolonged courses of very toxic and difficult to administer medication. So there really was a need for new, simple treatments for cryptococcal meningitis, particularly ones that were feasible and could be delivered in the lowest resource settings where most of these patients are getting sick and most of these people need to get their treatment. So how did we go about developing new treatments for cryptococcal meningitis? Well, it's quite a long story and it starts quite a long time ago. So the first studies that I'm going to present started in 2004. This is a colleague of mine called Tihana Bikanic. And Tihana, with the support of my PhD supervisor and her PhD supervisor, somebody called Tom Harrison, went out to work with Graham Menkes, Linda Gale Becker, and Robin Wood in Cape Town in 2006, just as antiretroviral therapy was being rolled out across South Africa. And at that time, cryptococcal meningitis, it still is actually, but even more so then, was a major, major issue in the hospitals around Cape Town. And one of the first studies that Tihana and Tom did was developing a new technique that enabled us to assess drug regimens for cryptococcal meningitis quite rapidly, which involved doing lumbar punctures on our patients on day 1, day 3, day 7 of treatment, taking the CSF from these patients and doing serial dilutions. So these are each a 10-fold dilution of the neat CSF in the red top tube, plating out each of those dilutions on a Sabdex agar plate, and then counting the colonies. And by doing this and calculating, depending on which dilution you have, you can work out how many colony-forming units per mil of CSF you have of the cryptococcus, so the organism burden at the site of infection in real time. And then for each patient, you can plot a line and see how quickly are we clearing that infection from the CSF with our drug regimens. So this was a tool that was developed that then enabled us to do a whole series of studies developing new treatment regimens that we could test in subsequent phase 3 trials. One of the first studies that Tihana in the picture did there compared amphotericin B deoxycholate, the intravenous therapy, with fluconazole, the tablet, which, as I told you, was leading to mortality rates in excess of 70%. And you can see why fluconazole was leading to mortality rates in excess of 70% from this very neat study. Not many patients, but fluconazole was entirely fungistatic at the doses that we were using. Whereas amphotericin B, you can see those nice steep slopes. The patients are clearing the infection from the CSF. So some of the first studies that were done, these were done in Uganda by a colleague of mine, Nikki Longley, tried to increase the dose of fluconazole. Could we get dose-dependent increases in activity of this drug? The answer is yes, we could. If you increase the dose from 400 to 800 to 1200, you start to see these slopes getting steeper and steeper. But that still led, in a clinical trial, to over 50% mortality at 10 weeks. Clearly inadequate. But those studies led to international changes in dosing for fluconazole that we still use today, where we pushed the dose up from 400 up to 1200 milligrams. Adding in another oral antifungal drug called flucytosine increased the clearance of infection even faster. This is of relevance when I come to a later study. And again seemed to lower mortality, but still not as good as amphotericin B. So what are the issues with amphotericin B? Well, the problems with amphotericin B are that it's very toxic and difficult to use. So conventional treatment courses required a daily intravenous infusion of this drug. Now, daily intravenous infusions in a hospital in rural Uganda or Tanzania, where the nursing care is provided by patients' families, where there's one nurse for a ward of 40 patients, and you've got 6 meningitis patients at once, is very, very difficult to do. And it's toxic. It can cause a nasty chemical thrombophlebitis. That's the picture there. I'm not sure if it projects very well. It can lead to nosocomial sepsis from drip site infections. About 15% of the cohorts in Cape Town developed nosocomial sepsis when they were getting this treatment, often with highly resistant organisms, which are now prevalent across the hospitals we work in the region. It causes infusion reactions. It causes a median drop in hemoglobin of 2 grams per deciliter over the 2 weeks of treatment, which when you're starting with profound anemia and a hemoglobin of 8 is very significant. Renal impairment, potassium, magnesium wasting. It's a hard drug to use. So we needed to define some better ways of managing this. One possibility was just giving less of that same drug. So these are data from a group in Liverpool we work with, William Hope and colleagues, looking at, in a rabbit model, well, what happens if we just give 3 doses of this drug rather than 14 days? The pharmacokinetics suggest that we're giving probably far too much of the drug. And in a rabbit model, 3 doses had exactly the same efficacy as 14 days of daily dosing. And in the brains of these rabbits at the end of this experiment, the fungal burdens were the same in the rabbits that received just 3 doses or 14 doses. So, well, there's one strategy. Let's try that in people. And Tom Harrison and colleagues did try this in people in a trial called the ACTA trial. It was quite a complex study. Don't worry too much about the graph, but the basic comparison was between 1 week versus 2 weeks of daily dosed amphotericin B deoxycholate. And in the red boxes there, you can see that actually 1 week wasn't just as good as 2 weeks, it led to significantly lower mortality. And that's almost certainly because, like in the rabbits, we were getting the same fungal clearance, but we were avoiding all of that horrible toxicity in the 2nd week of treatment. So this study, again, changed global guidelines quite rapidly, but we're still giving 1 week of a toxic medication requiring daily intravenous infusions. So we wanted to do better. And in this country, we'd never give standard amphotericin B deoxycholate. We'd always use the liposomal formulation, which is far less nephrotoxic, which means that you can give much bigger doses. And it hangs around in the tissues very, very well, suggesting that we should be able to give very effective treatment with very short courses, maybe even a single high dose. And in fact, we had proof of concept from another infection, visceral leishmaniasis, where doctors in India had done studies showing that in visceral leishmaniasis, you could give a single 10 milligram per kilogram dose of liposomal amphotericin and get the same outcomes as giving 14 days of the standard 3 milligram per kilogram dosing. So we thought, well, this could be applied to cryptococcal meningitis. And the reason this drug hadn't been used across Africa was the cost. So a conventional course of amphotericin B deoxycholate cost about $16 per patient at the list price of the drug. A conventional course of liposomal amphotericin B for 14 days cost over $5,000 per patient at the list pricing for the drug. So when we started planning some of these studies, there were many people who were saying, well, you shouldn't be doing these studies. Nobody in Africa can afford this drug. But our take was different. We thought, well, if we can prove that with just a single dose, we can get the same effect as 14 days of dosing, that will make it much, much cheaper. And then we can advocate to the drug companies to get this provided at a donation price, which they already did for visceral leishmaniasis. So we set out to try and define the most effective and cost-effective schedule of using liposomal amphotericin B for cryptococcal meningitis in this trial, the AMBITION trial. So going through the AMBITION trial now, the first step was a phase 2 study done in Botswana at Princess Marina Hospital, in Tanzania in Mwanza at Bugando Hospital. And we had 4 arms in this study, and the end point was this rate of clearance of infection metric, early fungicidal activity that we'd devised in those early studies in 2006, 2007. We had a control arm, which was 14 days of the daily ambisome infusions at the standard dose. And then we had various short course arms, a single 10 milligram per kilogram dose at day 1, 2 high doses or 3 high doses. And the bottom line is there, but if you look at the panel on the right there, this is our non-inferiority analysis, because we set this up as a non-inferiority trial. We just wanted to show that a single dose was no worse than 14 days of dosing due to the practicality and feasibility requirements. And what we showed, in fact, was that the rate of clearance of infection was faster with all of the high bolus dose arms than it was with the daily standard dosing. And we showed that there was no suggestion here of a dose response effect. It didn't look like giving a second or a third high dose made any difference. It looked like we were getting maximal efficacy with a single high dose. So this formed the background to our phase 3 ambition trial, which was that cryptococcal meningitis is a major cause of mortality. We had the global burden of disease estimates that we'd come up with. Conventional treatment with amphotericin B deoxycholate was significantly toxic. We'd shown that we could give shorter courses of the conventional format, and we had our phase 2 data showing that a single high dose of the liposomal form seemed to be the optimal way of dosing this drug. So we set out on a phase 3 trial where we were comparing the standard at that time amphotericin B deoxycholate regimen of 1 week, based on that first trial I showed you, comparing, that was the WHO standard at this time, comparing it to our single 10 milligram per kilogram dose given just on day 1. And we ran this trial across 5 African countries, 2 sites in Uganda, 2 sites in Malawi, Zimbabwe, Botswana, and South Africa. And the outcomes are shown here, and I think if you look at the death from any cause at 10 weeks, that was our primary endpoint. The single dose arm is the yellow, so you can see that our single dose actually led to lower mortality than the conventional 7 days of daily dosing, which was the WHO standard at the time. It was much, much easier to give, of course, requiring just 1 infusion rather than 7 days of daily infusions. And it was significantly less toxic, causing significantly less renal impairment, less anemia. And it was favored by both the providers and the healthcare workers. So really a result that we were very, very happy with. And that trial then led to quite a rapid change in global policy. So for the next 10 minutes or so, I'll just run through what happened and how that happened. So when we initially presented the results at a conference, it certainly picked up some interest within the infectious diseases world and the HIV world. Médecins Sans Frontières, who were very involved in activism and advocacy around this, put out a large press release and kicked up a bit of a fuss, mainly directed at Gilead, the drug manufacturer of liposomal amphotericin, to tell them that they needed to get their house in order and provide this drug at a reasonable cost to Africa if this was going to be implemented. And in response to that, Gilead put out a statement, as we'd hoped, saying that they would indeed provide this at cost for this indication in Africa, bringing the price down from $5,000 to about $160 per patient. So a very rapid change in pricing and global access potentially as a result of that trial. We published the results in March of 2022, 24th of March, and just 3 weeks later, the World Health Organization issued rapid advice changing the global guidelines to include this as first-line therapy for cryptococcal meningitis treatment globally, which is the fastest change in policy I think that's ever happened in a WHO guideline. But even more importantly than that from our perspective was that patients in the countries we were doing the study and beyond were getting this treatment in routine care paid for by their own governments just 3 months after publication of the trial. And it also led or helped to facilitate some of the renewed activism around AIDS and advanced HIV disease. So after years of going to HIV conferences and everybody talking about new cure research or CAR T-cell therapy or who knows what, suddenly we had activists storming the stage in Montreal at the first in-person AIDS conference after COVID, waving signs around. They need to work on their spelling a bit, but you get the message that cryptococcal meningitis is a big problem, and hey, there are these treatments out there now that make a difference. We need to have access to these treatments. So it really stimulated some global advocacy. So how did we do this. How did it happen? Well, it wasn't by accident, and it was as a result of a concerted effort that started well before we started the phase 3 trial. So just running through the steps here, the first thing, I think, is to ask the right question. So our team doing this work, made up of many of the leading infectious diseases clinicians and researchers across the African continent and collaborators in the UK, had been working in these settings for decades. They knew what the clinical issues were, they knew what the problems were that they were facing, and they knew what kinds of solutions we needed. So we were able to ask the right question from the beginning. Do the right trial. As I've shown you, this idea didn't just come out of nowhere. This was based on a decade and a half or more of carefully curated basic science, phase 1 and phase 2 clinical trials that led up to the big phase 3 trial, careful PK work. So we had a very good evidence base to inform this question, and a good idea that the study would be successful before we set off. Engage the community. We've heard a lot about community engagement over the course of today. And of course, engaging the community to help you frame your question at the beginning is critical, but also engaging the community to make sure that this is implemented and translated into practice is absolutely critical. Engage the stakeholders. So engage the ministries of health, engage the World Health Organization, engage Médecins Sans Frontières, engage the drug companies who are selling this drug at $5,000 a shot. You know, we've done this all the way through the trial. The reason WHO could write their guideline 3 weeks after trial publication was, of course, because they knew about the results months and months beforehand, and they knew that we were doing this trial the whole way through the course of the trial. So we'd had ongoing dialogue and back and forth, and they helped inform some of our study questions. So that engagement starts early and is an ongoing process. Provide the key evidence for policy change. So as well as our clinical trial showing the efficacy of the regimen, we did detailed cost-effectiveness work making the economic case, which is a major part of getting governments to take up that intervention if you can demonstrate it's cost-effective. And we did work with our participants in the study and their families and the clinicians, showing that this was a highly acceptable and feasible intervention. And the WHO and, well, us and the WHO published this as an exemplar of how you can actually get research into policy very quickly, because they have their evidence to decision table, if you like. You know, what they need is to know the priority of the problem, so you need to have that global burden of disease stuff out there ready. They want to know the balance of benefits and harms. Well, that's the phase 3 trial. But they also want the acceptability data, the feasibility data, the economic evaluation data to help them all make that decision. And if you can provide that all at the same time in one nice package, then your translation of evidence into policy is going to be much, much quicker. The starting point of this paper was it's an average of 17 years from evidence being published to it making it into global health policy. 17 years. So if you can do, when you're writing your grants or doing your studies, you cost in the economic evaluation. You don't see this patient engagement work and the feasibility and acceptability work as a bit of a bolt-on. They're critical components of generating the evidence you need for policy change. So do them alongside your trial. We did a lot of advocacy work, and there's quite a broad coalition of people driving this advocacy and keeping advanced HIV disease and cryptococcal meningitis on the radar of the people who hold the purse strings. And of course, when you've gone through all of this process, your work is only just beginning. We need to now implement this into the real world. And throughout the trial, the pictures there are of several courses that we ran. We ran mycology courses, we ran good clinical practice courses, research methods training courses. We funded 5 MSCs and 3 PhD studentships through the study, of course, creating a cadre of champions across the region who could go out and help implement this. And we've got 2 subsequent funded studies, which I'll spend the next 5 minutes or so telling you about to try and implement this now. So that was the Ambition trial. And there was a wise Trappist monk called Thomas Merton who said, when ambition ends, happiness begins. So that was my hope. I thought I could finish the Ambition trial and I would be happy. But there was an even wiser Japanese Buddhist monk who said, ambition never comes to an end. And that certainly seems to have been how this has played out. So we've got 2 follow-on implementation studies going on from the trial now to enable us to try and implement this and move beyond just getting it into the guideline, but actually now getting it out into the clinics. The first is funded by the CDC. This is a U award. It's a non-research collaborative award, so it's the first time I've got a grant where they won't allow me to publish anything rather than encourage me to publish anything. And we've got, working across 4 of the countries that we did the trial in, so Uganda, Malawi, Zimbabwe, and South Africa, this project. The first element of it is engaging key stakeholders to get this into national guidelines. That was helped by the fact that the chair of the guidelines committee in Zimbabwe was our principal investigator for the Ambition trial there, that the people who write the guidelines in South Africa and Botswana were both our principal investigators for the study there, and that our Malawian team also sit on the guideline writing committee, so that was relatively straightforward. Drug registration, drug access, working with multiple people and partners to try and get the drug there. We managed to get some catalytic procurement through the Clinton Health Access Initiative to make these commodities available initially, and that's been picked up now by the Global Fund and PEPFAR, who have included these in their HIV commodities list. That's a picture of a training, a stakeholder engagement event we did in Uganda at the IDI. They sent medical officers or superintendents from every secondary level hospital across Uganda to this meeting when we disseminated the results. The bottom picture is Eltas, our clinical lead in Malawi, sitting at their HIV technical working group, discussing the Ambition trial. Training healthcare workers. We've now trained in person over 3,000 healthcare workers across the region on this novel treatment and cryptococcal management more broadly through the CDC-funded project. That's Seppo, our clinical lead in Botswana, doing a training in Botswana at the top. Admire, our Zimbabwean clinical lead, giving a very inspired talk to some Zimbabwean nurses there, and we've got various online resources to help with this. We're doing a lot of patient engagement work to increase patient literacy and improve health-seeking behavior and improve lumbar puncture uptake, which is a big problem for us in countries where there's been a big HIV epidemic and people have watched many of their family members and friends go into hospital having a lumbar puncture and then dying because their cryptococcal meningitis couldn't be treated. They associate the lumbar puncture with death, and they don't want to do that. And we had one patient in our trial who ended up, because for cryptococcal meningitis, the lumbar puncture is not just a diagnostic, it's therapeutic, because they get excessively raised CSF pressures and you have to do therapeutic taps to drain the CSF to keep them alive. And this patient in our study had 76 therapeutic lumbar punctures over the course of 46 days. So basically 2 LPs a day for a month and a half. And at our Ugandan patient engagement group meeting where we were going through some of the patient-facing materials, this is a picture of the team. There's David Lawrence and myself, Jane Gakuru, the lead doctor, but all of the people in the middle of that picture, from the 2 ladies in the dresses inwards, are all patients who were in our trial, had cryptococcal meningitis, and have now formed a patient advocacy group to really try and get the message out to people about cryptococcal meningitis, get them to present to hospital early, get them to have lumbar punctures. They all want me to share this picture and get the message out there. But it turned out halfway through the meeting that lady standing there in the green dress with her baby is the lady who had 76 lumbar punctures during the study. And so doing this patient engagement work is a profoundly important part of everything we do, and sometimes I have to say a profoundly moving part of what we do. So when I realized that was who this was, and I had of course been sitting there on the receiving end of emails and giving clinical advice about this, but then suddenly this person's there with her baby, and it's very nice having that personal reinforcement that what you do does make a difference sometimes. So the final part of this, monitoring and evaluation, and we do get to have a bit of fun. This is for you, Evelyn, Gaborone Dam. There we are having a bit of relaxation after a hard day's training. Now I'm running out of time, but let me just briefly tell you about the other implementation project we've got, which is an NIHR-funded global health group called Imprint. And what we're doing here is trying to apply the lessons that we learned from cryptococcal meningitis and apply them to other fungal infections that impact people with advanced HIV disease across Africa, PCP, pneumonia, talaromycosis, it used to be called penicillium in Southeast Asia, histoplasmosis, and an infection that's only recently been identified called emergomycosis in South Africa. We're expanding our global footprint now, working with Médecins Sans Frontières in some very low resource settings to expand the treatment and expand the work to Guinea, to DRC, and to Mozambique. This was our launch meeting in Cape Town. And just to highlight that through this, again, training and capacity strengthening is a key part of what we're doing to try and expand the impact of our work and allow it to be sustainable going forward. So through the Imprint Group, we've got 3 funded PhD studentships, 2 in South Africa, 1 in Vietnam, and we've got 5 funded MSc placements. So 4 of them named, 1 yet to be defined. So now there's 5 minutes to go. So why is it important to attend the drinks reception? And I do realize at this point I'm the only person standing between you and the drinks reception. So 5 slides on why it's important to attend the drinks reception. So another aspect of our work has been not just trying to treat people once they get cryptococcal meningitis, but we asked the question, well, can we prevent people from getting cryptococcal meningitis? The pathogenesis of this infection, as I mentioned right at the beginning, is that we're all exposed to this fungus. We breathe it in, it goes into our lungs, and it sits there probably in a latent infection, walled off by our T cells in a granuloma. And if your T cell count starts to decline with HIV, your CD4 count goes down to 200, 150, this reactivates and it disseminates. But of course, potentially we could detect people after this is reactivated, but before it's got into their central nervous system and before it causes a devastating meningitis. And we could intervene here by detecting cryptococcal antigen, which is a very, very easily detectable component of the wall of Cryptococcus or the capsule of Cryptococcus in the blood, identify people before they get meningitis and treat them. And part of my PhD in Cape Town was doing a study where we demonstrated that indeed you can use cryptococcal antigen detection very well to identify people who have early cryptococcal disease before they're sick. In fact, it had 100% negative predictive value. If you were cryptococcal antigen negative at baseline when you started antiretroviral therapy, you would not get cryptococcal meningitis. If you were cryptococcal antigen positive, you had about a 50% chance of developing meningitis in the first 3 months of HIV treatment. So you could do this. Now, what was stopping the widespread rollout of cryptococcal antigen screening was the fact that to detect cryptococcal antigen, we had to do what's called a latex agglutination test. This required taking the serum of patients, boiling it in a water bath or heating it in a water bath to 90 degrees, putting it out on a series of little agglutination plates, reading. It was quite a complex, involved process. It required lab staff and time, and it required expense. So what we needed was a point-of-care antigen test. I presented this data at the 7th International Conference on Cryptococcus and Cryptococcosis. So we're a small group, the cryptococcologists, but we have good conferences. And this was in Nagasaki. They lay on a very good drinks reception, so even my hopes are high for tonight. And at this drinks reception, I was there with Tom Harrison, who's in the rather natty black kimono in the middle. I'm on the side there in my younger days. And we got chatting to this man here, Tom Cazell. He was also wearing a kimono at the time, but I don't have a picture of him there. And Tom Cazell studies antibodies in mice. And he had some very, very good antibodies that bound with extremely high affinity to cryptococcal antigen, but he didn't really know what to do with them. And at this drinks reception, we got chatting and we said, well, you should put this in a lateral flow test. We could have a dipstick assay for Cryptococcus. And that is exactly what happened. So 2011, 4 years later, we published the first evaluation of the lateral flow assay for Cryptococcus. 99.3% sensitivity, 99.1% specificity, about $1 a test. Takes about 10 minutes or 10 minutes to do. So this is basically a perfect diagnostic test. And that is what enabled us to go from those data about the natural history of Cryptococcus to a cryptococcal antigen screening. So this was first put into WHO guidelines in 2011 after we published that validation, and is still in WHO guidelines where they recommend now that everybody with a CD4 count less than 100, and in fact probably less than 200 who's starting antiretroviral therapy, should be screened for cryptococcal antigen. So a very rapid pathway to impact. And just to demonstrate a bit of that pathway to impact, this is in South Africa, the CRAG screening program, just in one country. And since 2017, when they implemented this, they've screened 1.6 million people with a cryptococcal antigen test, and 90,000 people have been identified with early cryptococcal infection. 90,000 people who we probably have prevented from getting a life-threatening meningitis. And that South African rollout was led by Professor Nilesh Govender, head of the Centre for Healthcare-Associated Infections and Mycoses at the NICD. And there's Nilesh in his kimono at the same drinks reception. So thank you for listening. Go and enjoy your drink reception, and you never know how many lives might be saved by the conversations you're about to have.
I knew you'd be brilliant, Joe, but I didn't realise quite how brilliant. And you feel somewhat embarrassed and humbled, thinking, I've known Joe for all these years, and I hadn't really understood just how impressive the work that you've done with an extraordinary amount of people. So thank you very much, Joe. And the bar is quite high for those conversations that you're about to all go and have. So hang on, that was in 2008. So someone do the maths for me quicker. In however many years, let's see what story will be told at a future conference like this. Joe, thank you very much.